Tonight we have the honor of having Dr. Abdul Rana. He's a neurologist from Toronto, Canada, and head of the World Parkinsonism Project, and a very dedicated educator of Parkinsonism to penetrate the different areas of the world, including India and Pakistan, with uses of technology like this. Before I turn it over to Dr. Rana, let us introduce the panelists. And let's start first. Yourself to Dr. Rana.
From Pakistan, and I'm a medical graduate, and I'd be glad to hear you. I have obviously good interest in neurosurgery. I plan to pursue it as a career.
Okay, welcome, FIFA. Francesca.
Hello, I'm Francesca Poslaro. I'm from Romania, a sixth-year medical student. I'm interested in neurosurgery and actually the president of the Walter Dendy Neurosurgical Club for medical students here.
Welcome, Francesca. Gaurav, please.
Hello, Dr. Rana. Nice to meet you. It's me, Gaurav Bhattar from Nepal, and I'm a fourth-year medical student, and I study in College of Medical Sciences, Nepal. Thank you.
Thank you, Gaurav. Hira.
Nice meeting you.
Hello, Dr. Rana. This is Hira from Pakistan. I'm the founder of ACNS Neurological Student Society, collaborating with Pakistan Neurological Student Society to bring down clinical students interested in neurosurgery on a platform to talk to neurosurgeons and neurologists. It's good to have you here with us.
Good, nice meeting you as well.
Slaven.
Hello, my name is Slaven Gojkovic. I'm from Zagreb. I'm a medical student leading the Dendy Club here and other student organizations in neurosurgery, and I'm delighted.
That's Slaven Gojkovic. He's a medical student from Croatia. He's the head of the Walter Dendy in Croatia. And Yusuf, could you please introduce yourself to Dr. Rana?
Yeah, hello, I'm Yusuf. I am a fourth-year medical student from Law Medical College, Pakistan, and I plan to pursue a career in neurosurgery. It's nice to have you here. Thank you so much.
Thank you for coming, Yusuf. Okay, Dr. Rana, it's all yours.
Nice meeting all of you. Thank you for arranging this today. So we will be talking about non-motor symptoms of Parkinson's disease. So my name is Abdul Rana, and I'm a neurologist, and I have been working in the field of Parkinson's disease for several years. So as Dr. Bennett said, I enjoy teaching and as well as educating patients about Parkinson's disease. And I started a charitable organization, World Parkinson's Program, in 2008, which is currently registered. It's a Canadian-based global organization, which is focused on providing patients their daily needs, such as Parkinson's disease medications, walking aids, and educational literature. And we have published educational literature about Parkinson's disease. We have developed brochures, educational brochures, which have been translated in more than 20 languages, and they are used in more than 50 countries. And it's a set of brochures. These are 14 brochures, and they have been translated, as I said, in more than 20 languages, and they are used around the world. These are to educate patients. And as you know, education is the first step in the treatment of Parkinson's disease. So I love to talk about history a little bit. So when we talk about history, as most of you know might have heard, that the most detailed and up-to-date account of Parkinson's disease was given by James Parkinson in 1817, and he was a British physician who published this essay, Shaking Palsy, 200 years ago. This April was 200-year anniversary of Parkinson's disease. So, however, if you look at history, the descriptions of Parkinson's disease have been found much earlier than James Parkinson's in the ancient literature. In India, the Ayurvedic system, 5000 BC, there have been some descriptions about Parkinson's disease. There is a text from Egypt. If you look at it, it says that the divine old age has slackened his mouth and he cast his spittle upon the ground and spit it out. So this statement is likely talking about a king who had Parkinson's disease, and he used to drool time to time. In 1776, John Sager, in his article, he writes that in Vienna, I saw a man above the age of 50. He was running involuntarily, and he was unable to keeping directions so to avoid obstacles. And I'm sure you might have understand, some of you, that what is he talking about. Any idea? He's talking about fastination. Fastination is a very typical phenomenon seen in patients of Parkinson's disease when they're running involuntarily, they're walking, they're running faster at a faster pace involuntarily, and they're not able to stop, and sometimes they can fall. In 1829, the first known patient of Parkinson's disease, William Humboldt, he was a German scholar, and he writes that I'm sorry for having written in such unclear manner. Unfortunately, only too often I cause people to trouble in deciphering my handwriting. So he's talking about micrographia, and he is the first known patient of Parkinson's disease. James Parkinson, he described 60 at the age of 62. He described six patients in the essay Shaking Palsy, and in this essay he mentioned many features of Parkinson's disease. And as you know, that Parkinson's disease was named as Parkinson's much after him. The major symptoms of Parkinson's disease on which the diagnosis rests is still the motor symptoms. Motor symptoms are resting tremor, slowness of movements or bradykinesia, stiffness or rigidity, and postural instability. So these are the motor symptoms on which the diagnosis of Parkinson's disease rests. Anyone has idea that any famous personalities who had Parkinson's? Anyone among the panel? Hello?
We do have a politician in Pakistan, as far as I know of.
Who is the politician in Pakistan?
We do have one politician, I think his name was Mr. Aziz. He's a known politician from good party, and he is
no, I mean the globally known person. So Muhammad Ali, Muhammad Ali, boxer, the greatest boxer in history. I'm a big fan of Muhammad Ali. Muhammad Ali had Parkinson's disease. Similarly, Pope John Paul II, he also had Parkinson's disease. So the diagnosis of Parkinson's disease, it does rest on motor symptoms. Unless you have motor symptoms of resting tremor, bradykinesia, rigidity, and so you can make a diagnosis of Parkinson's disease. However, the non-motor symptoms of Parkinson's disease, the list of non-motor symptoms is increasing day by day as we are learning more about Parkinson's disease. So we are learning a lot about the non-motor aspects of Parkinson's disease. Just to mention, in 2009, we decided to compile a list of non-motor symptoms of Parkinson's disease, and we came up with a handbook, 50 ways Parkinson's could affect you. And I published that handbook. And then in 2013, probably, we revised that, and we decided to gather more information, and then we came up with 99 phases of Parkinson's disease. So you can imagine how the list is increasing and how many systems of human body this disease affects, and how many social aspects of human life are affected by Parkinson's disease. Non-motor symptoms of Parkinson's disease, they cause poor quality of life, they do cause caregiver stress, and also they are responsible for the long-term care placement of patients. And non-motor symptoms of Parkinson's disease, they may start much before the motor symptoms of Parkinson's disease. So screening for non-motor symptoms is important because patients may not know that these non-motor symptoms are part of the disease, and they might just simply think that these are due to aging, and therefore they may not bring these symptoms to the attention of physicians. So physicians have to take initiative of asking patients about the non-motor symptoms of Parkinson's disease, and many of the non-motor symptoms may become more important in the wearing off periods. Once the effect of medication wear off, then these non-motor symptoms may become more prominent and they may affect patients more. And I think most of us have heard about loss of facial expression, or hypomimia, or facial masking, or a mask-like face. This is referred by many different terminology in the field of neurology. So the first thing you see a patient, you see, look at their face. So you look at it and you see that their face is expressionless. So expressionless face or hypomimia, this is a very common symptom of Parkinson's, and this is noted by other people, other family members or friends who meet patients. So they notice that after some time, their face become expressionless. They lose expressions on the face. And sometimes if a patient is waiting for you in the waiting room and you're busy in your clinic, so just by looking at their face, you can have a diagnosis. So loss of facial expression is very important. It is different from a related condition, progressive supranuclear palsy. I'm sure you guys have heard about that condition too. That is atypical Parkinsonism. And just to differentiate, in atypical Parkinsonism, the facial expressions are usually more prominent. They are usually they have very prominent nasolabial folds and frontal folds, and their face look more as with the deepening of these frontal and nasolabial folds, whereas in patients with Parkinson's disease, the face is usually flat or expressionless face. Micrographia, or small size handwriting, is another symptom which may start many years before the other symptoms of Parkinson's disease. These patients usually go to the bank and they sign on their check, and sometimes the teller would not honor their check because their signatures have increased, they have changed, they have decreased in size. So these patients also could have difficulty with fine motor tasks such as fastening their buttons, brushing teeth, or trimming their hair, etc. So these patients may have difficulty, and it may also start on one side of the body and many years before other symptoms. So you can also see decreased blinking in patients with Parkinson's disease. So they don't blink often, and they are looking as their eyes wide open and kind of astonished appearance on their face. So this is part of lack of facial expression, decreased blinking of eyes. Drooling or sialorrhea, as I was mentioning in that Egyptian text, that this old divine has slackened his mouth and caused to spittle out. So that statement was talking about drooling. Drooling is seen in more than 70% of patients with Parkinson's disease, and initially drooling may start very mild and at night time. Patients usually don't appreciate any other symptoms. So these patients wake up in the morning and they find their pillow is wet. So they talk to their family members. No one can find out why they have this wet pillow. Sometimes they go to dentists and they believe that this is due to their dentures or their problem with their teeth. So the dentist looks at their teeth and nothing seems to be wrong. So these patients try to ignore this, but this increases, and gradually the drooling becomes a problem. And as the disease progresses, the drooling starts in the daytime as well. And flexed posture in Parkinson's disease, the stooping of posture does not help drooling. It leads to increased drooling, and sometimes drooling or accumulation of saliva in mouth can lead to aspiration of saliva, and as a result, patients could have aspiration pneumonia, which could be cause of death in many patients with Parkinson's disease. Speech problems become also an issue because speech is the main mode of communication. So patients with Parkinson's disease, they have hypophonia, soft speech, monotonous speech. They lose the tone. Like when we speak, according to the circumstances, we change the tone of our voice. So these patients have a one tone, like in all situations, their tone is about the same. Monotonous speech, their pitch is reduced, they have difficulty stressing on their speech, they have a breathy, hoarse quality, and they do have difficulty with articulation, and they could have short rushes of speech. Sometimes they could have start hesitation. So when the speech problems start, so these patients think that they have sore throat. So they go to their GP. Their sore throat does not heal in 1 week, 2 weeks, 3 weeks. It keeps on going. Sometimes the GPs refer them to ENT doctors. They look at it. There's no pharyngitis. There's no erythema in their throat or any swelling or any other issues. Sometimes these patients are given antibiotics, several courses, so it does not help. So these patients usually have a vocal cord bowing. They have vocal cord tremor in 50% of patients, which makes this worse. So there is also a dysfunction of intrinsic laryngeal muscles, which causes decreased rate and increased variability of motor unit firing of larynx. So there is also a less activity of thyroarytenoid muscle, and there is a problem with intraoral pressure when they try to vowel production, which leads to a problem with speech. And these patients, when they have problem with speech, they are asked by people to repeat themselves, and that leads to embarrassment, and these patients may have been socially withdrawn because of this embarrassment. They start going out, and they start taking part in the group sessions or the conversation with multiple partners. Sometimes these patients may have the difficulty with the words which start with P or B or S or F, and at other times these patients may get stuck on these words. When they start the conversation, they may have start hesitation. They might take multiple attempts before they can start pronouncing a word. So there is there's a trouble with the reduced with the range of motion of the speech muscles. Jaw movements are also decreased, and there is rigidity of speech muscles, and about 10% of patients may speak at a faster rate than the slower rate, and that faster rate also causes trouble with the understanding of other people. Balance problems are very common in patients with Parkinson's disease. There are many factors which can contribute to this. First of all, the factors like non-neurological factors such as arthritis, decreased hearing, trouble with their vision, pain or joint problems. In addition to these, there are some changes in the gait of patients with Parkinson's disease, such as their base becomes narrow, they have bradykinesia, their stride length is decreased, they have a delayed reaction time, there is postural hypotension, and these patients have difficulty turning, freezing of gait, impaired axial rotation. When we walk, we have a normal axial rotation, and there is a reciprocal oscillation between thorax and trunk, and these patients seem to lose this. There is a need of more steps to turn effectively in these patients, so these problems contribute to loss of postural reflexes, and falls become common in these patients, and because of falls, these patients can have fractures, and as a result, they may end up being hospitalized, and they may suffer other complications of hospitalization. I gave the example of fascination in the beginning. Fascination is a very typical phenomena seen in patients with Parkinson's disease. These patients seem to walk at a faster rate than normal, and sometimes they can't avoid any obstacles and they may fall. I still remember a patient who I saw. The patient was at a bus stop, and he was trying to catch a bus. So he was a little bit late, and the bus started running. So he started running behind the bus, but he could not catch the bus. And someone from the window was watching him, and they saw that when he was running to catch the bus had left, but he could not stop running. He kept on running, and he could not stop himself. And as a result, he fell down. And this is how he sustained some injuries, was brought to hospital, and as a result, when they assessed him, he was diagnosed with Parkinson's disease. Even James Parkinson in 1817, when he published his essay, he said the propensity to lean forward become invisible in these patients, and they march quicker in shorter steps. So he was talking about fascination in these patients. Fascination is described by their family members as these patients are walking faster because their legs are trying to catch up with their upper body forward motion, and they can't do this. So the fascination is associated with freezing of feet, and it could have serious consequences. Talking about freezing, so freezing is a sudden arrest of mobility. It's a common symptom in Parkinson's disease, sometimes seen in the early stages also, although mostly in moderate to late stage of Parkinson's disease. So these patients have inability to generate effective stepping. It affects legs more, and then these patients feel as if their feet are glued to the ground. So it may occur when they are starting to walk, so start hesitation. Say they are sitting and stand up, so before starting to walk, their feet get frozen to the ground. They can't generate stepping, so that start hesitation. Then when they're turning, the freezing can happen again. So if they go through tight places, so such as stepping into elevator or going on to a hall doorway, so that could cause a problem as well. And when they reach the destination, so they could get frozen again. I hope everyone is with me and are able to follow me. Is everyone with me? Everyone can hear me?
Yeah.
Yes.
Thank you.
Yes.
Yes, sir.
Yes, of course.
Well, I'm hearing you.
I didn't see Dr. Bennett's response, or maybe, I don't know if he fell asleep. I'm sure he's awake and with us.
I'm sorry, Dr. Rana, I was on mute. I'm sorry. Do you want to open it up for questions?
No, I'm just starting. We have a lot to go.
Okay, very good. Continue on. As they say in England, carry on.
Yes. So these patients with freezing, they have difficulty dealing with the barriers, such as time-restricted activity, revolving doors, heavy traffic areas, and stepping into an elevator. For these patients, going up is relatively easy than going down, because when they're going up on the stairs, they are seeing the stair edge. The stair edge acts as a cue, mental cue for patients with freezing, so they can step easily. But when they are coming down, because they are not looking at the steps, they're looking straight. So I believe that is one of the common cause of these patients, that going upwards is easy than coming down for these patients. Freezing was more recognized in 1970s, and it has a very complex relation with levodopa. So freezing could happen when patients are on, which means that when levodopa has started working. And freezing could also happen when the effect of
So your sound has been muted.
Hera, please unmute it if you can.
You're accidentally
please-
muted, Dr. Rana. You're muted accidentally. Click on your mute
How
button. Click on your mute button, Dr. Rana. Can you hear me okay?
Dr. Rana?
Click in the upper part.
Mute.
Actually, you can do something from here. Control room.
The red
Go to
box.
box here.
Now can you hear me?
Yeah.
Yes, sir.
Yeah.
You can hear me now?
Yes,
Yes,
we
sir.
can. Yeah.
Yes.
Thank you, thank you. So as I was saying, that freezing of gait or freezing overall, it could happen during the wearing off periods or on periods. As the disease progresses, as you know, patients with Parkinson's disease, they develop these motor fluctuations on and off. On mean the levodopa has started working. It takes about 20 minutes to half an hour, and they go on. During on period, they can do things easily, and then after several hours, the effect of levodopa starts to go away, so wearing off. So freezing mostly happens in wearing off periods. However, in about 10 to 20% of patients, it can happen when they're on as well. The on freezing gets worse if you increase the dose of levodopa. It's very important to remember, because what happens if you don't differentiate the freezing, whether it's an on or off period, and you just increase the dose of levodopa, assuming that this would help. If they have on freezing, it would make it worse. These patients will start falling more. But if the freezing is in the off periods, then it might help. Or other strategies to help with the wearing off periods. Dual tasking, such as cognitive load, can increase the freezing, whereas focused attention and external cues can help to overcome freezing. Freezing is more common in atypical Parkinsonism, such as in vascular Parkinsonism. So what we do in freezing, we use a very simple technique. We take a cable tie. You can buy a cable tie from any dollar store. You can buy 100 cable ties of $1, and you put at the down edge of the cane and leave the end of the cable tie pointing. And tell patients when they are frozen while they're walking, they look at this pointing end of cable tie and they try to overcome this. They try to step over this. The moment they try to step over this, they break the cycle of freezing. So this is a very easy technique to overcome freezing of gait, and it prevents falling. So one of the common problem patients with Parkinson's disease suffer is falls. As I said before, balance problems, freezing, and changes in gait, and as well as postural abnormalities in Parkinson's disease. They all lead towards falls, and about 70% of patients fall each year, and about 10 to 15% fall more than a week. And there are many other risk factors, such as postural hypotension, because patients have low blood pressure. When they stand up, their blood pressure further drops, so they have delayed reaction time. They can't hold on to themselves, and their reflexes are slow. They have dementia. They have slowness of movements, and also due to aging, they have certain changes in joints in the other parts of their body. So they are not able to handle that situation, which leads to fall. In addition, arthritis, as well as poor vision, muscle weakness, these can also lead to falls. Falls are very serious issue in Parkinson's disease. Patients may, if they hit their head, they sustain intracranial bleeding or serious injuries. They can have fractures that lead to hospitalization. And once these patients are hospitalized, they suffer from other complications such as pneumonia and bed sores, and they're prone to infections, etc. So I always tell my patients that when I teach them fall prevention strategies, that if you want to stay out of hospital, if you want to stay healthy, you should follow the fall prevention strategies. Memory or cognitive issues for Parkinson's disease dementia, It's very common in patients with Parkinson's disease. About half of patients suffer from dementia. Initially, these patients may not have any significant problems which are noticeable, but as their condition progresses, these patients start getting difficulty with frontal executive function. They have trouble with the planning, organization of goal-directed activity. They also have difficulty with set shifting, visual spatial problems, learning, memory, etc. becomes a problem as the disease progresses. Language in these patients remains relatively intact as compared to Alzheimer's disease. So this is a very common question in exams, or your mentor might ask you the difference of dementia, the Alzheimer's dementia and Parkinson's disease dementia. So in terms of language, the language in Parkinson's disease patients is relatively intact as compared to patients with Alzheimer's disease, in which the language function worsens. So the cognitive issues are accompanied with psychomotor slowing. They have fluctuation in attention, in cognition. They have issues with mood as well as personality, and some of these patients may develop hallucination, psychosis, and as the disease progresses, patients may have difficulty with praxis as well as recall. The risk factors for cognitive issues are old age at the onset of disease, severity of motor disorders, depression, and family history of dementia. So dementia should be addressed in these patients. Patients who have vascular risk factors with Parkinson's disease, physicians should pay attention to addressing, to have a good glycemic control, addressing hypertension. If they have high cholesterol, that should be addressed as well. So addressing dementia and screening for dementia at a good time or early is always helpful, and it leads to early treatment and better prognosis in these patients. Cholinesterase inhibitors are helpful in these patients. They may also have behavioral issues. In addition to dementia, these patients may have behavioral issues which are accompanying dementia or psychosis. So psychosis with confusion and hallucination may be seen in about 20% of patients, and with hallucinations and dementia, eventually anywhere between 40 to 70% patients may be affected. The patients who have a early psychotic reaction with dopaminergic medications, that may be indicator of later development of dementia. Psychosis could be drug-induced in some patients. For example, if patients are using medications such as amantadine or anticholinergic medications such as dihexyphenidyl, although these medications are rarely used in Parkinson's disease patients, but they can also trigger psychosis. Selegiline and levodopa or dopamine agonists can also lead to psychosis. These patients have visual hallucinations which are more prominent, and auditory hallucinations are much less in these patients. If they're present, they're usually accompanying visual hallucinations. So visual hallucinations remain the main type of hallucination in these patients. Their visual hallucinations are very detailed, they are well formed, and they usually are non-frightening. These patients usually don't get frightened by visual hallucination. Most of patients can understand that the hallucinations they are experiencing, these are related, they are not real. So as the disease progresses, the hallucinations become more issue, and the hallucinations are very common in the evening time or night time. These patients report that they see their deceased relatives. Sometimes they will see animals in the house, or they will see birds, or they will see things outside window which don't exist. So this should be screened, and the treatment could be very simple, and a very low dose quetiapine might be helpful for these patients. Mood problems remain a main issue in patients with Parkinson's disease. These patients have dysthymia. They may not have very frank or obvious major depression, but they may have just a dysthymia with lack of interest, and they don't enjoy their daily activities as they used to enjoy before. They might feel sad. Some patients may have anhedonia, lack of initiative. They may lose the assertiveness. And when you talk to these patients, when you are asking them to make a decision about their treatment, they might be looking towards their spouse because of this lack of initiative, lack of assertiveness. So these patients may lose the decision-making initiative. Some of these patients may develop into a major depression, and it's very important to screen these symptoms, and these symptoms should be treated. Other patients may have anxiety, so they may be more irritable, they may be indecisive, so anxiety may lead to shortness of breathing because these patients are hyperventilating subconsciously, and their main complaint may just be hyperventilation. Usually, depression is more prevalent in patients with Parkinson's disease, and anxiety and depression may coexist. So these patients may have symptoms of both of these disorders. They may have loss of interest, fatigue, irritability, and this may start many years before the motor symptoms of Parkinson's disease, and their risk factors remain the same as in general population. For example, age, being a female, gender, having family history of depression, these are risk factors for depression. So these mood problems are due to involvement of multiple neurotransmitter systems such as dopaminergic, noradrenergic, and serotonergic systems are involved, and therefore these patients suffer mood problems. As I just mentioned about anxiety, some patients may feel dizzy. They may have palpitations, sweating, feeling of passing out, loss of control, and fidgety, and panic attacks. Some patients may get into panic condition, and their families have to play a big role in addressing those issues. And as these patients have developed on and off periods, as the disease progresses, so cyclic anxiety is not uncommon in these patients. When they become, when they come in off periods, they become anxious. When they're on, they're relatively better. So as these on and off periods go on, the anxiety goes on, and it becomes cyclic. Sleep problems are seen in more than 2/3 of patients. Most patients report sleep fragmentation. They have multiple awakenings in the mornings, and they have difficulty falling to sleep again. Some patients have difficulty falling asleep at the onset of night, and when they go to bed, they may stay awake for longer periods. And other patients may have excessive daytime sleepiness. In the daytime, they are dozing off multiple times. They're taking many different naps, and a small subset of patients, about 15 to 20% of patients, may have RBD, REM behavioral disorder. I'm sure you're aware of this, that this is noticed by their family members during REM sleep. These patients are yelling, shouting, and they're flailing their limbs, and sometimes their spouse may say they're trying to choke them or punch them during sleep. Patients really don't remember this when they wake up in the morning. So REM behavioral disorder is much more prevalent than initially we thought. It's much more common because their nighttime sleep is not sufficient due to sleep fragmentation and multiple awakenings, so they feel sleepy during the day, and sometimes about 5% of patients may have sudden onset of sleep when they are busy in important activities such as driving. They may feel sleepy or dozing off. So it's very important to discuss these issues with these patients. So there are many factors which may lead to sleep problems, such as cramping. Many patients have leg cramps. They could have restless leg syndrome. Also, nighttime need to go to washroom, nocturia. They have to urinate multiple times. Sometimes if they have visual hallucinations, or they are depressed, or they have anxiety or confusion, that also prevents them from falling asleep. If they have early morning dystonia, if they have turning in of their toes or foot in the morning, that wakes them from sleep. Sometimes nightmares or night terrors, also lead to issues of sleep. Some patients have been noticed they are walking during sleep, or they are talking very loudly, and eventually their spouses leave that room and they start sleeping in a separate room. This becomes a problem. This can be addressed easily. You can do a sleep study to further assess this issue, and if they have RBD, a very low dose of clonazepam at bedtime might be helpful. These patients have neurodegeneration, and they have reduced slow wave sleep, and they also have decreased sleep efficiency. There is also some suggestion that the circadian rhythm in patients with Parkinson's disease is disrupted, and in addition to their nighttime poor sleep, that circadian rhythm abnormalities may lead to excessive daytime sleepiness in these patients. So sleep is an important issue to address. Patients should be screened for these issues, because if patients have a good nighttime sleep, then they can cope well with their symptoms during the day, which is called a sleep benefit. That's seen in many patients with Parkinson's disease. And if their nighttime sleep is no good, then their day would not be good. So, so the physicians should take initiative to screen these patients for the sleep problems. Pain is another symptom of Parkinson's disease that could affect their night or day. Pain is less understood, less studied. The chronic pain in patients with Parkinson's disease is seen in more than 2/3 of patients. Pain is sometimes accompanied with numbness, tingling, aching, or leg cramps, and some patients may report very excruciating pain. The pain affects more lower body, like legs, feet, and toes, and also pain may affect joints, the proximal joints, such as the shoulder joint, etc. Pain remains more prominent on the side affected by Parkinson's disease. As you know, Parkinson's disease usually starts on one side of the body first. It starts gradually and then progresses to the other side. So in the initial stages of disease, the one side of the body remains more affected with the motor as well as non-motor symptoms. But as the disease progresses, it involves both sides. So pain may be more prevalent on the side which was involved in Parkinson's disease. So these patients may have more pain when they are wearing off or when they are waking up in the morning, because the effect of medication from last night is gone. So the pain is felt more. These patients have altered central pain processing. They have dopaminergic denervation, which causes central hypersensitivity to painful stimuli through basal ganglia and thalamic connections, and that causes feeling of pain in these patients. The Lewy body pathology also affects the central pain processing, and some reports have suggested that these patients with pain are relatively younger. They have more severe motor complications, and they also have more depressive symptoms. Some of the older reports also suggested that the pain could be intense, and the pain in Parkinson's disease is less reported to the physicians as compared to pain due to other causes, and it may be less associated with the use of analgesics. So the pain in Parkinson's disease could be due to Parkinson's itself or due to other causes which may affect patients, such as arthritis or musculoskeletal abnormalities or back problems. So the pain related to Parkinson's disease is usually less often worsened by physical effort. It usually starts after the onset of Parkinson's disease, and it is less frequent before the onset of Parkinson's disease. And pain related to Parkinson's disease could get worse during the off periods. And when you treat patients with dopaminergic medications, so the pain which is more due to Parkinson's disease will improve. So these tips might help to differentiate the pain which is due to non-Parkinson's disease issues versus pain due to Parkinson's disease. there are many different categories of pain felt by these patients, such as they may have aching pain, they may have akathisia, dystonic pain. Sometimes they may have pain which is similar to patients with neuropathy that affects more legs and feet and is accompanied by sensory symptoms. And sometimes patients will have abdominal pain. In these patients during their off periods, they get a severe pain in their belly. They go to emergency, they see Dr. Bennett, and sometimes if they are not able to report their history very well or provide their medications, so these patients may be thought to have acute abdomen, and then surgeon may be called to assess them. But when they take their levodopa or Parkinson disease medications, then their pain goes away. So that is a helpful tip to differentiate that pain is due to Parkinson disease, and some patients may have low back pain as well, and that could be attributed to Parkinson's disease. So postural abnormalities and altered muscle tone in patients with Parkinson's disease could lead to pain. And during the off periods, the generalized pain, neuralgic pain, a tightening feeling, tingling, numbness, and burning sensations are common words which patients use to describe their symptoms. The loss of sense of smell, hyposmia, is a very common symptom of Parkinson's. 90% of patients may have hyposmia. It starts much before the onset of motor symptoms of Parkinson's disease. So if you go back to these patients and ask that how is your sense of smell, they would say that some patients will say that they were never able to smell, or they would say that decades ago they lost their sense of smell. So these patients have difficulty appreciating the smell, and this is more common in idiopathic Parkinson's disease as compared to atypical Parkinsonism. Patients with progressive supranuclear palsy or MSA or vascular Parkinsonism may not have poor sense of smell or loss of sense of smell. So this could also help students to differentiate this from idiopathic Parkinson's disease and atypical Parkinsonism. And this is due to involvement of olfactory system with the Lewy body pathology that these patients stop having the capability of odor detection and odor identification and discrimination. There is a University of Pennsylvania test which you can use, smell identification test. So with loss of sense of smell, we should briefly mention loss of taste. So some patients report that they have difficulty with the taste and they are not able to taste their food as good as before. The exact cause of loss of taste does remain unknown. With the taste, I think comes dysphagia or swallowing problems. So these patients start noticing initially a very mild catch when they are eating or drinking. Sometimes they might cough when they are drinking fluids. So there is a combination of dysfunction of the oral, pharyngeal, esophageal phases of deglutition in Parkinson's disease, and therefore they have poor bolus formation, lingual festination. Some patients could have they could have a repetitive tongue elevation during the oral phase. The swallowing reflex is delayed in these patients, and there is incomplete relaxation of upper esophageal sphincter, and there is a problem with esophageal peristalsis and gastroesophageal reflux. So these patients suffer with the swallowing problem, and as the disease progresses, this problem worsens, and sometimes it may lead to placement of G-tube, or they have to go on a liquid diet. So also some patients have chewing problem. They're slow, they're not able to chew. So that leads to poor dental care because the food remnants are left in mouth, and because patients on top have motor dysfunction, they are not able to, they have hand-mouth incoordination, they are not able to brush their teeth. So poor dental health and poor nutrition are the result of Parkinson's disease. Constipation is a very common complaint of Parkinson's disease. About 90% of patients have constipation. These patients may not have bowel movement for days. And I remember one of our patients who presented with constipation. This patient could not have bowel movement for about 10 days. And they thought that this was due to the use of analgesics for his back pain. So he was sent to a spine surgeon. The spine surgeon said that he does not need surgery. So his back pain should be managed by a neurologist. So then he ended up seeing a general neurologist. General neurologist noted some lack of arm swing on one side, and they referred to our Parkinson's clinic. So this is how this patient was diagnosed with Parkinson's disease, with the constipation. The whole thing started with the constipation. The guy could not have bowel movement for 10 days. And then we have to give him so many laxatives and stuff like this to help him to overcome constipation. One of the common things which we use is prune juice. Prune juice is very helpful in these patients for eating prunes and a high fiber diet. So these things are very, these tips are very helpful to most of these patients. Because these patients have trouble with chewing, they have difficulty with swallowing, they have less sense of smell as well as taste. They have poor hand-mouth coordination. They have depression, nauseous feelings sometimes, which is worsened by medication. So this all leads to poor nutrition. They start eating less, and therefore they suffer poor nutrition and weight loss. As the disease progresses, patients start losing weight. So you have to pay real good attention on their dietary habits, and their diet has to be modified and make sure that they don't lose weight. Frozen shoulder, I'm sure most of us have heard, especially while surgery rotations. You guys might have seen patients with frozen shoulder. These patients, much before the other symptoms of Parkinson's disease, they start developing pain in one shoulder because they're not swinging their arm. So this problem gets worse and worse. And these patients, they are thought of having rotator cuff issues. And we have seen patients who undergone surgery and they were referred to us later, and they had frozen shoulder, which was related to Parkinson's disease. Because of lack of arm swing, the rigidity, and bradykinesia, they have limited range of motion, which contributes to this problem. And frozen shoulder patients undergo various tests such as x-rays, ultrasound, nerve conduction studies, the steroid injections, and the injections of local anesthetics, and injections of other analgesic medications. But at the end, if someone notices the other symptoms, then they are referred to a neurologist. And this is how this frozen shoulder comes to attention. And a dopaminergic medication may help to some extent. Because Parkinson's disease starts on one side, so the one side is lagging behind, patients may be bent over to that side. So if patients have a pre-existing scoliosis, Parkinson's disease can make it worse, and it can cause worsening of the curvature of their spine to one side. Because these patients are sitting most of the time, they're less mobile, so their rate of bone loss is higher than rate of bone formation. Therefore, osteoporosis and fractures occur with a much higher frequency in these patients. Since our bone mass is maintained by bone formation and bone loss, so the rate of bone loss is higher, which causes weakening and thinning of bones, leading to fractures. And exercise and day-to-day mobility helps to maintain bone mass, and we advise most patients or all patients to exercise during all stages of Parkinson's disease. If they cannot do active exercises, they should have the passive exercises with the help of their family members. Restless leg syndrome is a condition by itself. Patients have increased urge to move their legs. They describe in common words that jumpy legs. This phenomenon starts in the evenings, in the beginning of the course of disease. When patients start walking, the symptoms become less prevalent. So if these patients take a plane ride, or they have to stand up and walk around in the plane, or if they are sitting in a car as a passenger, sometimes patients may have to stop and they have to get out of the car to walk around to get rid of this feeling. The restless leg syndrome in common public may be found anywhere between 5 to 7%, but when it comes to Parkinson's disease, in association with Parkinson's disease, some reports have even suggested up to 25% prevalence of restless leg syndrome. And my senior colleagues and teachers like Dr. Arthur Walters and Dr. Bill Ando has done a lot of work on restless leg syndrome and its association with Parkinson's disease. So restless leg syndrome should be differentiated from symptoms of polyneuropathy or cramping, and it should be addressed in these patients because restless leg syndrome may be associated with low iron level or renal dysfunction. So these patients should undergo these basic serological investigations to rule out any other causes, and then treatment with respect to restless leg syndrome is very important. The restless leg syndrome also affects sleep of patients because these patients, when they lie down in bed at night time, their legs become more uncomfortable and they have to stretch their legs. Sometimes they have to come out of the bed and walk around in the hallway to relieve that feeling, and symptoms of restless leg syndrome can worsen during off periods. Urinary bladder problems such as urgency of urination, nocturia, a feeling that the bladder is not empty, or a desire to go quickly. Even if they have urinated, they have to go again and again because the detrusor muscle in these patients become hyperactive. And there could be a dyssynergia between the urinary sphincter and the detrusor. When the detrusor contracts, the internal urinary sphincter should open, but sometimes there could be a paradoxical co-contraction of the urethral sphincter with the detrusor muscle, and this could be worsened in off periods. So therefore, these patients may suffer from bladder dysfunction, and the hyperactivity of detrusor muscle leads to urge incontinence, and it gets worse as the disease worsens. Sexual dysfunction is also commonly associated, and it's a manifestation of autonomic dysfunction, and these patients have ED, and not only men are affected, women could be affected with this as well. Since this is a difficult topic to talk with physicians, so it's better if the physicians initiate the discussion so that patients don't suffer in silence, and this should be addressed. Postural hypotension, we had a brief discussion before that due to autonomic dysfunction, patients have a increased gap in their blood pressure when they're sitting or lying. When they stand up, their blood pressure drops. And some of these patients, long time ago, they were started on antihypertensive medications because of essential hypertension, and no one has assessed their blood pressure again. And their antihypertensive medications are renewed again and again, continued in the same way. So that further worsens the postural hypotension. So ideally, a difference of 20 in systolic and 10 in diastolic blood pressure from supine to standing is defined as postural hypotension, but it could be milder in some patients, and it can lead to dizziness, lightheadedness. Some patients may have fainting spells. They may go into syncope. So the first thing is to assess this and then see if they are on any blood pressure medications, and also other strategies such as fluid intake and compression stockings, drinking a glass of cold water in the morning. So these strategies may help to improve the maintenance of blood pressure. Because these patients have a sympathetic denervation, so the postural hypotension becomes more of a problem in these patients, and to prevent falls, this should be addressed. Sweating is also a common manifestation in patients with Parkinson's disease. Sometimes they have episodic sweating, like they have drenches of sweat. And if the patients are middle-aged, they might feel that in females that this is related to menopause. So this is a symptom of autonomic dysfunction. Men or women, they both may have drenches of sweats, and their clothes, you will see, they're wet, and this is episodic. It happens randomly, and it's very difficult to address, and it's quite bothersome for patients. As disease progresses, these patients develop hand and finger problems. They have postural difficulties. Some patients may have double vision. Other patients may have internal tremor. They might feel that one side of their body has a tremor inside. So you need to make sure they don't have cardiac arrhythmias, and then you have to educate them that this internal tremor is related to Parkinson's disease. Fatigue is another symptom. These patients are done by noon, and they can't continue their day without a nap. So they also have difficulty completing their daily activities because of fatigue, which is a very important non-motor symptom of Parkinson's disease. Nausea, anorexia, and vomiting happens in some patients, partly due to constipation, decreased GI motility, as well as medications. Confusion and hallucinations, sudden sleep attacks should be addressed as well. Leg swelling and libido reticularis could be a manifestation of some medications such as amantadine. So these patients, they should be screened thoroughly. In our routine visits, we take 45 minutes for a follow-up patient and 1 to 1.5 hours for a new patient for Parkinson's disease. So these patients should be given a proper time, and the important non-motor symptoms should be screened. Patients should be provided educational material in their languages so that they can know about the disease, and they can also become a part of the team to manage their disease. As I mentioned before, World Parkinson's Program has developed educational brochures about Parkinson's disease in Urdu as well as Hindi, Arabic, in many languages. So you can just give a package of those 14 brochures when patients are visiting. That would lead them to understand many of their symptoms, and they can bring that into attention of physicians. So always you need other physicians as part of treatment, such as a psychiatrist, urologist, physio and speech therapist, social workers in the same team, so that other problems can be addressed as well. I think it has been a little bit longer talk than Dr. Bennett anticipated initially, so I'll take questions.
Okay, Dr. Rana, thank you very much for a comprehensive review of a disease that affects so many systems. And I forget how good you are, because we've done more than 60 videos together, and you cover all aspects of Parkinsonism. And one thing I hope you get from this panel is that I hope you can network with some of the Pakistani people to help plug into the Pakistani network of Parkinsonism, because I'm sure there are organizations in Pakistan that deal with Parkinsonism, and I know that you're interested in educating the world on Parkinsonism. So why don't we start the questions off first with Victor. Victor, do you have any comments or questions you would like to? Oh, by the way, this is Dr. Rana. This is Victor Hugo Perez from Mexico City. He's a neurosurgeon.
Is he there now, or?
Yeah, he's here right now. Victor, say hello to Dr. Rana.
Hi, Victor. You're in Mexico?
Yes.
From Mexico City. Yes.
He's a neurosurgeon and a neuroanatomist from Mexico.
Nice meeting you.
Nice to meet you too.
¿Cómo estás? ¿Cómo estás?
Bien, hablas español.
Gracias.
Felicidades, congratulations. Very nice lecture.
Thank you.
Okay, thank you, Victor. Okay, any questions from the panelists or comments?
I have one question. It's a very small question. Maybe you have covered this previously, but I wanted to ask about the variation of the presenting symptoms in different age groups. Does that matter, or it's a common thing in all of the patients?
Usually symptoms are same in all age groups. Most patients would be presenting the resting tremor, because you can see the resting tremor, although the most common symptom, according to most experts, is bradykinesia, or slowness of movements. But because slowness of movements can be attributed to aging, so patients may not pay attention to slowness of movement. But because the tremor can be seen, obviously it can involve index finger or the thumb just on one hand, and it could be very mild, but because it's obvious, people can see this. So that becomes the most common symptom, although 70% of patients have the resting tremor, and more patients have bradykinesia, or you can see all patients have bradykinesia. So the presenting symptoms are about the same in all age groups. However, in young onset Parkinson's disease, they have more cramping and stiffness as compared to older patients. Older patients may have, as the disease progresses, more cognitive issues.
Okay.
Okay. Any more questions from the panel?
How important do you think is the DBS therapy today for Parkinson's disease? I think it will completely become more important than medication therapy in the future. Can you comment on this? Where do you see the DBS of today according to medications?
Patients who develop motor fluctuations, and these motor fluctuations become refractory to medications. When patients develop motor fluctuations, they develop wearing off, so you try to address with medication. However, some patients may develop refractory motor complications. We try all strategies, and they just don't work. So patients who have refractory motor complications, they are good candidates for surgery for Parkinson's disease. The mainstay of treatment for Parkinson's disease is still medications. You always start with medications. Patients do need physiotherapy, speech therapy, and exercise or rehabilitation is a very important modality to use. However, as the disease progresses, the effect of medications become less and less prominent beyond stage 3. And a time comes when some patients have refractory motor complications. So carefully selected patients do benefit from deep brain stimulation or other types of surgery. Parkinson's disease, however, most of the time these patients have a very strict criteria, such as age less than 70, not having dementia, and any other terminal conditions. And these patients should have symptoms of Parkinson's disease which are responsive to levodopa. So then they would benefit from surgery. The mainstay of treatment still remains medication.
Thank you very much for your answer.
Other questions from the panel? Afia, FIFA, or Garab, or who else? Joseph, any comments or questions? Or Francesca? Okay. Any further comments or questions, panel, or we're all set? Okay, well, Dr. Rana, it's so good to see you again. I haven't seen you for a while, and I'm glad to see you're still continuing to educate, and you do have regular shows on Facebook Live, correct?
Right. We do every first Saturday of the month. So next October
So I do have a request. If you could send us or email us one of your online brochures on Parkinsonism, so that we could circulate it on our Facebook pages as well.
So all our brochures about Parkinson's, they are listed. They are on the website of World Parkinson's Program. The website address is pprogram.org. P as Parkinson's disease, D as disease, pprogram.org. You go to Resource Center, Then you go to brochures. Then they are listed for many languages. You can pick your language and you can print it there. So it's very easy for physicians in office. They can ask their staff to do so. You go on the website, print the brochure, and the brochures are about, the first brochure is about introduction of Parkinson's disease. Second one is about the medication. Third one is caregiving. Fourth one is the healthcare team. Then we have a brochure about sleep, and then exercise, then falls, then driving and drooling, and hallucinations and emotional issues with Parkinson's disease, urinary dysfunction. So whatever problem your patient is facing, you can print that brochure quickly or give the website address to patients. If they have someone in their house who is familiar with computer use and printing, because most patients are elderly, they can benefit from the website. It's a big source of information, and information is there in Spanish. We have brochures in Spanish, Italian, German, Urdu, Hindi, Bengali, and French, and so on, and Turkish. So all sorts of main languages, Arabic, they are there. And these brochures can be printed from website. If someone cannot print, they can email at info@pdprogram.org. The team of World Parkinson's Program is happy to mail the hard copy of brochures to you. And they have been doing this for many years. Thank you.
Okay, well, Dr. Rana, I'm going to show right now your website so that people will be able to find it. Is your Facebook page the main website of your organization? This one here, this Facebook page of the World Parkinson's Program. Is this your main page? Can you see it? Okay, I'm sorry. I'm not sure. Am I sharing that screen? Can you see it okay? Can you see it okay, Dr. Rana? That screen?
Yes.
Yeah.
Can you see it okay?
Dr. Rana's audio is muted.
Can you guys see that page okay?
Yes,
Yeah.
yes, we can.
Okay, that's the Facebook page. If you punch in
Dr. Rana, could you unmute your audio, please?
Can you hear me now?
Yes, we can hear you.
Yeah.
Yes.
Yeah. If Dr. Bennett, if you can go to pdprogram.org, that is our main website. That has all the resources.
Oh, okay. Could you tell me the link again, please?
pdprogram.org.
Okay. Let me see if I can find that. In the meanwhile, if anybody has a question or comment, PE program.
No, PD program. PD, Parkinson's disease. PD.
Oh, PD program.
.org.
.org. Okay,
Yes.
Parkinson's disease. Okay, we're coming up. It's coming up. Okay, that's probably it, right? There we go. pdprogram.org.
Yes, yes. This is the main website.
Okay,
And,
this is a website where you can give HIRA some information.
Yes, yes. And the physicians can even request medications for their patients free of charge. Those patients who cannot buy medication, if they email through this website, so this organization provides medications free to patients, levodopa. They provide walking aids such as walkers, etc., canes, and educational literature free of charge in any part of the world. So please use this website and email them to help your patients.
Okay, very good. pdprogram.org here. Do you get that address?
Yeah, I shared the address in the chat.
Okay, good. And I'm sure if we run across any programs here in this part of the world, Dr. Rana, have you traveled extensively in Pakistan and India?
I have traveled to Pakistan many times, and my last trip was last November when I gave a talk in Aga Khan Hospital and Liaquat Medical School on Parkinson's disease. It was mid-November, and I gave a talk in Qatar in the same trip. Before that, And then from there, I went to Lahore, and then I had a talk. So I had traveled to these countries, Middle East, Saudi Arabia, Qatar, and UAE, Dubai, in Pakistan, to talk about Parkinson's disease. And any of the physicians who are interested to start a chapter of World Parkinson's Program in their country, so they can email through this website at info@pdprogram.org their brief bio and interest, and then one of the board members who is in charge of overseas chapters, they will get connected, and they will start sending them brochures and other supplies free of charge to provide to patients. So you can help your patients through this website, pdprogram.org. And we are very eager to open new chapters in countries like Nepal, India, Bhutan, because many of patients due to poverty, they are not able to buy their medicine. That was the theme of this this program, World Parkinson's Program.
Well, you know, Dr. Rana, we think we're going to grow. The neurosurgical TV community is going to grow, and we'll certainly keep in contact with you, and maybe have more presentations. But one quick question: the role of deep brain stimulation, which really concerns the neurosurgical community. Do you see it as something that's getting more common in the treatment of Parkinsonism, or stays the same since you've known it?
No, I think it's growing. The use is becoming more common. The only problem is that we don't have enough experts in countries like India or Pakistan or Bangladesh who can do this. We, you know, before a patient is referred to the neurosurgery team, they see a movement disorder neurologist. Even there is a great lack of movement disorder neurologists in countries like Bangladesh, Pakistan, and India. So this field is growing. We are using deep brain stimulation more and more since it was started. So I think it has a big potential, and as disease affects many younger people as well, they can benefit it even more. So I think the potential is big. And also, I would like to comment on the Hangouts. I think this Google Hangout is the excellent way of bringing people together. See, when we go for conferences, we have to travel, go through borders, customs, and sleep deprivation and jet lag, and take time from office, and so many fees and those things. I think if Dr. Bennett is the pioneer of this Google Hangout program, and I think this is his passion to bring the medical scientific community together through this platform. I think as we're doing this more, I'm hopeful that it would be further defined, and a day would come then we don't have to travel so far for conferences, and everyone can be at their place and join these conferences. We can have the conferences through Google Hangout. Like one I participated through Dr. Bennett, I think 2 or 3 years ago, probably in 2013 or 14. This was in Spain. It was also, I had a talk on Parkinsonism, and that was a great conference. I think this is this has a big potential. It's so easy to give talk, participate, listen, and interact through this means that a time will come in future that those big gatherings in hotels with thousands of people and all the traveling, we can avoid that, and we can learn through this means. And I really appreciate Dr. Bennett's effort. I think once this field grows more, his name would always be remembered as a pioneer to set this system up. And I was one of the first people who he taught, and I learned from Dr. Bennett, and I enjoyed this. And we did, I think it was in maybe 3 years ago that we did, every night we had a different topic, and we did about 60 Google Hangouts. And remember, patients always tell me in my clinic, oh, I went through your hangouts with Dr. Bennett from Florida. I learned about this symptom very well. So Dr. Bennett is a great name in the history of Parkinsonism as well, not only internet medicine, but Parkinson's.
Well, Dr. Rana, thank you very much. I enjoy doing those. We did a lot of videos. I'm glad to see some patients got some use of that. But I really see good potential for the neurosurgical community here. That's why I came to Nepal to work with a big neurosurgeon. I think we're going to grow. And I really would like to invite you, if you feel that it's worth discussing deep brain stimulation amongst in Parkinsonism. We'll talk about this later, but I think that this neurosurgical group would like to hear about that. If you'd like to give a talk on that sometime soon. Would you like to do that?
Sure, I'd be more than happy to do so, and we can talk on email, and we will plan a hangout on details of deep brain stimulation.
Yeah, we'll be in touch, and we'll continue to grow, and we'll try to help you get established in this part of the world through hangouts, and hopefully we can introduce you to people like Hira that are active in Pakistan, that we can show how to use the hangout technology. And if you have anybody, contact people, we'll be glad to introduce them to how to do a hangout, so that maybe you could explore it without leaving your home in Toronto.
Right. Thank you so much. It was nice being with the big panel and Dr. Bennett again, and I think we will meet again soon.
Okay, very good, Dr. Rana. Thank you very much, and thank you for all the panel for coming out. And we'll be continuing to do these in the future.
Thank you.
Thank
Okay,
you.
good night.